Well, we've just heard great talks from Barry and from Otis. We've heard an appeal for randomized control trials and thinking about overdiagnosis, among other things. My job here is to kind of put this together into a framework. And as Sue said, I'm Alex Krist. I'm a family physician at Virginia Commonwealth University. In 2 weeks, I'm going to be the chair for the U.S. Preventive Services Task Force. So that's kind of the lens I'm going to take as I'm talking about a framework. There's a number of task force members here as well and on stage also, current and former. So I'll try to do it justice. But to put this into perspective, the U.S. Preventive Services Task Force has 134 recommendations on 84 topics. We're getting together this Thursday and Friday, and we'll be making 5 more recommendations. So this is an ongoing process, and this slide just shows what we did in 2019. That was just that 1 year. We've heard an appeal on why this is all so important, and a very basic framing to be thinking about is, well, prevention's being done on healthy people. It's being done on people without signs and symptoms, and we have this risk of taking someone who's feeling well and is healthy and making them have an unhappy face, as Barry showed us. So we need to be careful about not doing that. And most people who we apply cancer screening to are not going to get that cancer, but they all have the same risk of suffering from the harms from the screening tests. So that just means that we have to think about that very carefully. So here's some principles I want to talk about in terms of cancer screening, and I'm going to try to show you how we operationalize this. I mean, this should be a systematic process looking at the evidence. We need to base this on health outcomes. We need to think both about benefits and harms. It should be reproducible. So if you put different people together looking at the same evidence, they should be able to come up with the same recommendation. It should be a transparent process that's free of conflict. It should be clear and actionable for patients and for clinicians. We need to respect patient values. I think we're going to hear that over this next day and a half, and we need to ground this in ethical principles. So these are all important concepts to think about. So the U.S. Preventive Services Task Force is a group of 16 volunteer experts in preventive medicine and evidence-based medicine, and the volunteer is an important part. That's part of that bit about being free of conflict. It's not a government body. This is not some entity that's making recommendations based on what we should do from a government standpoint. It's about what does the data show us? What does this mean for patients and for clinicians? And we're not conducting our own research. We're just looking at the evidence. And it's geared toward an audience of primary care clinicians, but could be used by any type of a clinician or patient. And I think we need to think over the next day and a half about the audiences that we're talking about, because recommendations may be different for different audiences. And as I said, this is for people without signs or symptoms, the basis of prevention here. We look both at the harms and the benefits and kind of systematically get input from a wide range of topical experts, and then have a process I'll show you where we get public input. This is an analytic framework that we use, and I want to explain this. This is how we kind of systematically identify the type of evidence that we need to be looking at when we're making our recommendation. And this is a systematic framework for screening. And as both Barry and Otis said, we're relying heavily on those randomized control trials. That top line with the little circle 1 in it, that's what we call KQ1 evidence or key question 1 evidence. So that means we're looking for trials that randomize people to be screened or not be screened and look at the whole outcome along that pathway. And that's what we call the direct evidence pathway. And I'll just say right now for cancer screening, all of our recommendations are based and require that there is direct evidence of benefit before we recommend cancer screening. Underneath, there's this indirect pathway, and we do look at the evidence for that even when we have big randomized trials like the ERSPIC trial and the Nelson and the NSLT trial. You look at the people who are at risk and what's the evidence and who's at risk for that cancer. You look at the screening test, what's the accuracy of the test, and then underneath you see what are the harms of that test and kind of add that up. We think about the people who are detected, who have early detected disease. That's similar to a screen detected population, which is different from someone presenting with symptoms. And then what's the evidence on treating that population? That's the number 4 there, and underneath you see the harms there. And then you see a box that's an intermediate outcome. So intermediate outcomes are some of the things that Otis mentioned, things like the length, survival time, and the stage of disease and other these factors. But ultimately, we need then to look at the morbidity and mortality, and does this extend the length of life, not just the survival time. For each one of these questions, and I don't want you to look at the words on that table, it's just to show you this framework here. We go through, and for each of these different questions, we have our PICOTS questions. So what's the population? What's the setting? What's the screening test? What's the comparison? What's the time frame? And for each one of these, we define what are the types of studies that we're going to include and what will be excluded. And so this is very much looking for those randomized controlled trials, for the KQ1 evidence, but for other things where we might be trying to link intermediate outcomes to health outcomes, we might be looking at population studies and cohorts. But it's a very systematic, predefined process on how we do this, and that's what this PICOT slide's about. And then we do what everyone here does from an evidence-based standpoint, and we apply the basic element, concepts and principles of evidence-based medicine, both to each of the individual studies, to the studies as a whole, and then to the framework as a whole. And we're looking at how good are the studies. So do they have the right research design to answer the questions we're looking at? Is there a sufficient amount of evidence for us to be able to say something? Are the results generalizable to a general U.S. population and specifically a primary care population? And are there enough studies? Are they big enough to answer these questions? Are the results consistent? And are there other factors? We often get hung up, and I remember in medical school I was mainly taught about the other factors, the biology, the pathophysiology, all these other factors that contribute to things. And they're very important, and when that doesn't kind of fit in with what we're seeing, we need to think about that. But that's a very small part of what we're looking at here. We've heard a little bit today about how we kind of think about benefits and harms. The task force looks at two factors really with each recommendation. So the first is certainty. So when we look at all this evidence, how certain are we that we can make an assessment on what the evidence is telling us? And this depends on both the amount and the quality of the evidence. And then we're looking at that magnitude of net benefit. So if you add up all the benefits, you take out all the harms, what's that magnitude of net benefit? If you've probably heard about our letter grades, A, B, C, D, and I. A and B typically means for clinicians to do this. C typically means do it potentially on select populations. D means don't routinely do it. This is the way clinicians often think about this. But from the task force perspective, what we're looking at is that certainty and magnitude of benefit. So an A means that we have high certainty of a substantial net benefit. And a B means we have at least moderate certainty of a moderate benefit. And a C, which is operationalized and doing in select populations, it still means we have moderate certainty that there's a small net benefit for a population. And then D's moderate certainty of no net benefit. And what's really important underneath there is that I. So we don't ever substitute expert opinion, professional judgment, clinical experience. It's just about what does the evidence tell us. This is how it's operationalized. I already said that. And we're looking at these two things, the health outcome and the intermediate outcome. So in order to make any recommendation, we have to demonstrate it that it improves the health outcome. Generically, we define this as extending the length of life or improving the quality of life. Intermediate outcomes are things that might influence us on getting to a health outcome, but just an improvement here alone is inadequate for making a recommendation. So a lot of these are lab values. Might be a blood pressure, a cholesterol, it might be a physical activity measure. For cancer screening, classic intermediate outcomes are number of diagnoses, stage shift, or survival time, the factors that we just heard about from Barry and Otis here. We do try to link those intermediate outcomes to health outcomes and say, what does the evidence show us about this? And I'll just tell you right now, we have no cancer screening recommendations where there hasn't been a demonstrated health outcome from the trials. We don't use that IO-HO link, that's what we call it, to make a cancer screening recommendation. We have for some other recommendations. So smoking cessation, quitting smoking is by our definition an intermediate outcome. But there's pretty strong evidence that if we get people to quit smoking, that's going to improve health outcomes. Same thing goes for this example of hepatitis C screening. So there's really, really strong evidence that if you have a sustained virologic response, that you're going to prevent a lot of morbidity and mortality. But we're extremely cautious in doing that. So here's our infographic for prostate cancer screening. We heard a little bit about prostate cancer screening, but one of the big challenges that we often face is that balance in assessing what is the net magnitude of benefit. And that's a challenge because the harms and the benefits aren't the same. So you think of the benefits for prostate cancer screening. The benefit of if 1,000 men get screened, 1 man won't die from prostate cancer, 3 men won't get metastatic disease. And if that were it, we might recommend prostate cancer screening for all men, but that, of course, is not it. The other harms are, as we heard, the overdiagnosis, the overtreatment, and the consequences from this. So, how do you balance the number of men who suffer from incontinence or impotence, or the number of men who go through false positives and then have to get prostate biopsies and might have complications from that? How do you weigh those against the benefits of preventing a death from prostate cancer? And to some extent, that's a personal value. So here's an example of a model where they kind of tried to add this up and assign number values, quality of life years gained or lost for the harms and for the benefits. And what you can see from this model is that there are these wide confidence intervals, and they vary very much depending on what you assign for things. So some men care very much about false positives and anxiety and incontinence and impotence, and some men care very much about doing anything to prevent prostate cancer. And that creates a unique challenge. And it creates a unique challenge, too, for trying to make population-level recommendations. So which perspective do you take? Do you take a mean? Do you take an average? Do you take a range? It has different implications when you're making your recommendations. So this is our bit about being transparent. So whenever we make a recommendation, there's this whole process. So to begin with, anyone can nominate a topic. So if you think there's a preventive service that the U.S. Preventive Services Task Force doesn't have a recommendation on, you can nominate a topic. And we look at that, and we think about, should we include this? Is this within our scope? Is there evidence where we can make a recommendation? The other thing is I showed you that research plan on how we search for the evidence. So we go through and we put together a draft research plan. We identify topical experts and organizations that care about that topic, get their input. We put it out there for public comment, and then we look at all of that, and we revise the research plan based on the public comment, and we think about that. And then we do the same when we get our evidence review from the evidence-based practice centers. We review all the evidence, we come up with a draft recommendation, once again, go through that process of getting all the topical expert input, getting public input, and then looking at that and evaluating it and thinking about, is there anything about the recommendation that we need to change? So having that transparent process that's hopefully reproducible is a core component of what we're trying to do. So I just mentioned here, all these are posted and anyone can nominate topics and anyone can comment on these. So from a clinician standpoint, and I can say this as a practicing family physician, we want answers. Tell us do it, don't do it. Don't give me that C recommendation and say do it on selective patients. Don't give me the I recommendation and say we don't know, you figure it out. That's really distressing for clinicians and patients. But I want to make an argument here that this is actually really important. It's part of what we need to know and what we don't know. So just like we need to know what the answer is, we need to know what we don't know, because that's how we fill those gaps. So at least from the task force standpoint, we put a lot of effort into identifying what we don't know. Even when we're making a recommendation and we think there's moderate certainty, there's still things we're not certain about. So every recommendation, we have a section that's the research gaps. What do we need to learn more about to answer, to fill? And then if it's an I recommendation where we're saying there's insufficient evidence, we're trying to put a section to kind of clue clinicians and patients on, well, how might you think about dealing with this now in our lack of evidence, although that's a difficult thing to do. But here's the life cycle that we think about, and I think this is an important grounding for this next day and a half, because it's part of the goal, I would think, from this forum is to figure about how to generate new knowledge. So we view this kind of cycle of evidence. So we start with a recommendation. If you start with us making a recommendation, let's say it's an I recommendation, every year we give a report to Congress, and we say, well, what do we know, what do we not know? And then NIH, Office of Disease Prevention, takes that report, tries to disseminate this to other NIH funding agencies. Hopefully we get grants that will fund new research to fill those evidence gaps. And then when we come back and do another systematic review in the future, some of these gaps have been closed and we're able to know more and recommend more for patients and clinicians about preventive services. So here's examples of our reports to Congress. You can see we had 2017 prostate cancer in African American men, 2019 was mental health, substance use, and violence, 2018 was cancer prevention and cardiovascular health. Very early on when we first did this, we looked at older Americans, then we looked at kids. So there's a range of these reports here. And I'll just stop by saying that everything that I've said is on our methods website, so there's nothing secret about this. We actually have a methods work group. Michael Berry chairs this work group, and we try to go and look across our processes and how we do things and find these gaps and even advance sort of the science on how we're approaching this and how have others approached it and what do we need to change with our methods and how will that influence future recommendations. So I think having a lot of attention to the process on how you do things is equally important. So with that, I'll stop.